you very much. These are my disclosures. So we're talking about 40-flow MRI, and you may all have seen these images. This shows an example here in a patient with single ventricle physiology after repair for Fontan circulation. And while these images look very appealing, there are, of course, real life problems or challenges, I should say, with this technique. And the two areas I want to focus on today is data acquisition, talk about scan times and flexible protocols, and data analysis. If we talk about scan times and data acquisition, initially these long scan times for these techniques were on the order of 15 to 20 minutes and have kind of relegated it to the realm of research. This has actually changed with parallel imaging techniques that have now been very efficiently actually integrated with 40-flow. This is an example here from our group together with colleagues from Siemens, where we have a compressed sensing version of 40-flow MRI, and you can see here with very excellent quality, acceleration factor of 10, very large field of view and complete coverage here of the thorax with really excellent visualization, and really only 5 minutes scan time with very isotropic spatial resolution. If you even take this to a more focused application, such as, for example, with aortic 40-flow MRI, as here, we've systematically looked at this as a cohort of 30 subjects. You can see that you can now reduce scan times for these applications to under 2 minutes on average. So now, and with very good agreement between the conventional and compressed sensing accelerated, both from the visual perspective, also from the quantitative perspective. And this really shows that if you think about how you perform 2D phase contrast MRI, it may take you a couple of minutes to place a couple of slides to a breath hold. You may actually now be at the point where you could potentially replace this with a 40-flow technique with really without any penalty for scan time. We can drive this even further, and this is work in collaboration with Matthias Struber's groups from Lausanne. This is very similar to what you saw in the last talk with the multitasking, kind of 5D imaging, fully free-running sequence where the respiratory and EKG signal are derived from the 40-flow scan itself. So we fill a kind of data space along respiratory, cardiac, and now also velocity encoding direction, and can very efficiently reconstruct this data set and arrive at these kind of 5D flow data sets where we can actually choose if we want to look at cardiac resolved, respiratory resolved, or just high resolution individual time frames 3D data set. And we can now also combine this with the flow encoding to add kind of flow to this equation if you like. Once you have that data, there's kind of a blessing and a curse to it. So it's very rich data. So you can derive a lot of different information from one data set, as shown here in this case with aortic type B dissection. So an angiogram, 3D streamlines visualization, or this velocity maximum intensity projection that nicely shows you the communication between the true and false lumen through this fenestration, or here the aortic valve insufficiency. But the curse really is, how do you do this very efficiently? And how do you really exploit the 4D information that you have in the data so that it makes clinical sense? So what are really the key applications? And once you identified those, how do you make it work very efficiently? And I'd like to show a couple of examples that also talk about the clinical translation of the techniques. And one prime example, or one important example in my mind, is heart valve disease, and particularly tricuspid and mitral regurgitation and stenosis. And the challenge is here, as you can see that, if you look at the motion of the base of the heart, there's actually a movement of the valve plane. And both echo and 2D phase contrast MRI are actually not good at all at characterizing mitral regurgitation or tricuspid regurgitation in this disease. So there's an opportunity, because we have the 40 flow data, to really track the valve and utilize the full 40 information to arrive at a better quantification in these patients. And this idea is not new at all. There's early work from US Westenberg groups, other work from the Stanford group, and very recently a nice publication in radiology that actually showed the potential value of these techniques, and it showed that with an efficient implementation, you can actually arrive at similar analysis times compared to 2D. You have improved consistency, and that's related to the fact if you do a whole heart 40-flow MRI scan, you have all 4 valves included, so you can do internal consistency checks. And what was very important, was they were able to show that the regurgitation severity would change actually by the 40-flow analysis, so there's a potential actually to change management here. One of the questions, though, is Although you've seen that you may arrive at similar analysis times with these techniques, they're still long, so there's a lot of work also going on in fully automating this technique. This is nice work from the Linköping group where they actually used an atlas-based techniques. So they assembled a series of 4D kind of vascular geometries, and then when they do a new 4D flow scan, they register it to that atlas and then can do a fully automated 4D segmentation and then fill that with the velocity information to do a more or less automated, at least visualization in this case. This is a big advantage and then kind of takes into account the anatomic variability you have in the data. One of the disadvantages still is that these algorithms take some time to process. So it's automated but takes time. So an alternative is, and you may have guessed it, is AI and deep learning. We've also become active in this area, and this is work by some of the students in my lab. And we've had the advantage or opportunity to have about over 1,000 aortic 4D flow data sets. They're really well annotated. So we looked into developing kind of more automated network-based analysis. And our approach so far has to be train different networks for pre-processing. So, for example, for eddy current correction, for velocity anti-aliasing, and also for 3D segmentation. And if you look at the performance at these, I was actually very surprised, but they do really well if you look at the dice scores in the area under the curves. And what I want to point out, and this goes back to Stefan Peterson's talk in the beginning, is that if you look at the standard analysis time for these techniques, if you have an experienced user, it will take you 15 to 20 minutes to do this type of pre-processing. That's absolutely essential before you can do any hemodynamic analysis. And you can get this into about 30 to 40 seconds or something like that. So again, that's one of the hallmarks of AI or deep learning that's so important here, that the training of these networks may take hours or days, but the actual applications is really very, very fast. And once you have these automated pipelines established, one of the nice features is then you can really easily take standard algorithms and really combine this with automated or at least semi-automated hemodynamic analysis or use other kind of approaches to do this. This is one nice example from Mohammed Elbaz in our lab, who's developed something he calls virtual catheter. It's kind of a structure that you deploy into the aorta that mimics the invasive catheter. And the advantage then is that you can then, similar to the real catheter, you kind of probe different hemodynamics along the catheter. And again, one of the advantages of 4D flow is you can selectively switch between hemodynamic metrics, such as, for example, kinetic energy or energy loss. Or alternatively, you could use the automated segmentation to quantify more advanced parameters, for example, such as wall shear stress in this patient here with a stenotic bicuspid aortic valve, where you see this elevated shear stress here. And while this may still be a parameter that's in the area of research, if you actually look at the literature, it's actually interesting that this is one of the areas where we have the most studies with the largest number of patients, up to 500 patients, that have actually shown that there's very promising physiologic links of changes in shear stress and development of aortopathy. So in summary, starting from the consensus statement on 4D flow that was published a couple of years back, we now do have sequences available at all scanners. Scan times of 2 to 5 minutes seem to be absolutely realistic. We have the 5D flow approaches on the horizon. There's many more efficient analysis workflows that have been developed. We start to see large-end studies. What's still missing, of course, is multi-center studies and outcome studies. And with this, I'd like to thank you for your attention.